Hi, everyone. For anyone who has just joined us online, you are catching us right after the lunch hour, so we're going to give it just a few more minutes before we go ahead and get started. Thanks. Okay, I think we're going to go ahead and get started. I know people are still trickling in from lunch, but we have a lot of ground to cover over the next just under 2 hours. So with that, good morning, good afternoon, and good evening from wherever you might be joining us. I'd like to begin with a quick audio and video check. Can those online hear and see me? Great. All right, thank you all for joining us during this day 2 installment of the Global Resilience Evidence Forum for what promises to be an engaging, provocative, and interactive cross-cutting session on health resilience, or resilience for health. I am very excited to be your guide for the next 2 hours that we have together, which I have no doubt will fly by. My name is Nefra Faltis, and I'm a Senior Child Health and Immunization Advisor with the U.S. Agency for International Development, or USAID's, Bureau for Global Health in the Office of Maternal and Child Health and Nutrition, Child Health and Immunization Division. I'm also joining you wearing a more cross-office and technical area agnostic hat as co-chair of the Bureau for Global Health's Resilience Technical Working Group. Without further delay, though, why don't we jump in and get started? We wanted to begin by giving you a sense not only of what to expect from this session, but also what we are hoping to learn from all of you during the session. Ideally, this will also be a conversation starter for what we hope will be many more exchanges and collaborations to come across sectors and well beyond the forum. One objective for this session is to highlight emerging work being done at the country and global levels to address evidence and learning gaps in resilience measurement, evaluation, analysis, and learning for health. Now, as you can imagine, this is an extremely broad field of inquiry. So where and how can we even begin? Well, we thought we would zoom in on measurement and analysis, both qualitative and quantitative, for health because there is a tremendous need for guidance, tools, capacity building, and experiential learning in these areas. The COVID-19 pandemic in particular has arguably popularized references to global health programming as building the resilience of individuals, households, communities, and health systems to the direct and indirect impacts of pandemics and other shocks and stresses. But demonstrating this, not just through narratives, but also through measurement and more rigorous direct and secondary analyses, has been much trickier. How can we sort of check in with ourselves and avoid the temptation to simply relabel much of what we're doing as resilience building? What distinguishes a resilience building health programming or measurement approach from one that does not intentionally integrate resilience? We need measurement, analysis, evaluation, and other learning to help answer these questions. And one defining feature of whether or not we can say that we're building resilience for health is whether or not we're attempting to measure it. So with all of this in mind, we'd like you to think about the following points as we make our way through today's discussions. No matter what your sector, discipline, or training, we are very eager to hear your thoughts on resilience measurement approaches, tools, and other resources that health sector actors can borrow from other sectors, barriers and opportunities to integrate health metrics and analysis into resilience programming and learning initiatives led by other sectors, what kinds of guidance, tools, evidence, and other resources are needed to enhance the development and use of resilience measurement and evaluation and analysis for health, and what may you have tried that maybe didn't work when it comes to resilience measurement, evaluation, analysis, and learning for health. This is our roadmap for the next couple of hours or so. We'll begin with some introductory presentations from several colleagues. Then we might break out into small group discussions or plenary, depending on our numbers, based on the 4 topics you see on this slide. In other words, 4 concurrent breakout group discussions, depending. We won't have time to take you all around the world in a World Cafe, but we'll try to at least take you to a couple of continents. I'm afraid if we do break out into breakout groups, our online participants won't be able to join us, but please do rejoin us for the breakout group report outs and closing plenary discussion that would follow. But first things first, let's start with some foundational definitions. What is health resilience or resilience for health? Well, for USAID, it's the ability of people, households, communities, systems, and countries to mitigate, adapt to, and recover from shocks and stresses in a way that reduces acute and chronic vulnerabilities and facilitates equitable health and nutrition outcomes. We developed this definition through an interagency process in 2020. It's derived from the agency's 2012 sector-agnostic definition for resilience. But when we defined health resilience, what we really wanted to do was include a focus on acute vulnerabilities, not just chronic stressors. And advancing equitable health outcomes and leaving no one behind are central to this definition too. This is where programming for resilience also offers critical points of entry for advancing priorities like localization and diversity, equity, inclusion, and accessibility. When it comes to measuring aspects of resilience in general and for health, we often start with trying to figure out how to measure three kinds of things: shocks and stresses, resilience capacities, and well-being outcomes like child mortality, use of family planning, or respectful maternity care, for example. We arguably have the most work to do in the health sector around defining and measuring resilience capacities, and then relating them to shocks and stresses and health outcomes, all of which also have to be measured. This graphic illustrates how programming for resilience is not just about bouncing back or recovering after a shock or stress. It's also about the active, deliberate management of the potential and realized risks of those shocks or stresses using certain abilities or resilience capacities. Why does this matter for health? Well, increasingly, of course, there's no context we work in that doesn't face constant, complex risks, whether there's a vaccine-preventable disease outbreak, floods, political unrest, health worker strikes, or maybe supply chain disruptions. And those risks present increasing threats to achieving sustainable development goals, not just for health, but also for other sectors. At USAID, we're often asked to contribute to briefers and taskers with examples of resilience building through our health programming. We do have a lot of intuitive and narrative examples, but we still have a long way to go, at least in a few areas. That includes integrating deliberate risk management, including climate risk management, into global health programming from the individual to systems levels. Our ability to measure and assess those risks as a precondition for being able to do that evidence-informed risk management and shock responsive programming. Our ability to demonstrate, especially through monitoring and evaluation, exactly how we're building resilience at different levels. This last point also reflects how measuring resilience allows us to answer questions that more traditional M&E approaches cannot. Questions like, what individual or household level behaviors allowed a pregnant woman to continue to seek antenatal care or maintain her health status in the face of a recent shock? Why was one health district and not its neighboring one able to maintain essential primary healthcare services in the face of a recent shock? We need to mobilize both sector agnostic and sector specific resources, including outside health, to help us answer these questions, not to mention advise our own implementing partners on how to do all this. I'm not going to review these slides, but this just represents an attempt at mapping different kinds of resilience capacities, shocks and stresses, and well-being outcomes for health to measurement methods. This is all very nascent, and we have to ask ourselves the question, what is the established evidence base for all this? Similarly, we can think of absorptive, adaptive, and resilience, transformative resilience capacities for health at different levels. And you'll notice in this table that some of those resilience capacities don't come from within the health sector. And that really underscores the fact that we need to measure things not just from within the health sector, but also from other sectors when we're considering those complex pathways to health outcomes. And finally, of course, we're sort of building the plane as we're flying it here, and you'll see this as a pretty consistent thread through our discussions today. All right, so with that bit of background and stage setting, I am now very pleased to introduce our first presenter, Dr. Sakif Mustafa, who's going to tell us about an exciting and much needed new resource on health systems resilience indicators that the World Health Organization, or WHO, is preparing to launch. Sakif is a technical officer at WHO HQ on health systems resilience and essential public health functions. He's a technical lead for WHO's health systems resilience indicators work, the essential public health functions workstream in WHO, and works on Partners Public Health and Emergency Workforce Strengthening Roadmap, as well as WHO's global reviews of COVID-19 preparedness and response plans in 106 countries. So he's a little bit busy. He has nearly 10 years experience working in health service delivery and in global health research policy and practice in many countries. He received his medical training at Edinburgh Medical School and the Scottish Centre for Regenerative Medicine. He also holds a master's and is a PhD candidate in global health policy at the University of Edinburgh, where he maintains links in teaching, the professional development of postgraduate students, and research. With that, Sakif, you have the floor.
Can you hear me okay? Thank you so much, Nefer. That's too kind. Too kind. So good afternoon, colleagues and friends, and a big thank you to Nefra and colleagues at USAID, as well as the Global Resilience Partnership for bringing us all together. I'm planning to speak for about 10-ish minutes, and this presentation is really just a flavor of the health systems resilience indicators package that we've developed from WHO, and perhaps in the discussion later, it's good that we're not too many folks. We can get really into it and get into a bit more detail. So looking forward to that. So thank you. Okay, sure. Yeah, thanks, Nefa. So I think a good place to start is why we developed this package of health system resilience indicators. And a lot of the things that Nefra touched upon are very complementary to what we're talking about, as well as what we've heard throughout day one and day two of this conference. So we've been discussing all these different stressors here. We're barely out of it from COVID, which has massive known and unknown consequences, some very visible and some less visible impacts. And the health systems of the world are facing enormous pressures in terms of workforce challenges, burnout, mental health challenges across the population, non-communicable diseases, multimorbidity, aging demographics, economic stressors, inflation, cost of living crisis, climate change, war and conflict, and natural disasters as well. We tend to address these things in isolation. And we often forget that it's the same one health system, the unit of action, the same one health workforce, the same supply chains, the same essential medicines and services that are at the heart of addressing these challenges. Next slide, please. So this slide shows the limitations in current approaches to measuring progress towards key global health objectives, such as universal health coverage and health security. There was no link between universal health coverage scores, joint external evaluation scores, and global health security scores and performance against COVID in terms of mortality. That's what the three messy figures show. Even high-income countries that are traditionally thought of as having strong health systems with high scores in these metrics were not able to keep COVID-19 mortality or morbidity low. So clearly we need to do something a bit differently. If we've really learned from this pandemic, moving forward, we need to focus on addressing clear gaps and developing these inherent baseline capacities of health systems in a more holistic and integrated way. This means proportionate attention and resources to public health and prevention, the role of primary health care, and addressing the broader social, economic, environmental, commercial, and other determinants of health. One of the key lessons of the pandemic was that a healthier a population is going into a crisis or a pandemic, the better your health outcomes are going to be coming out of that crisis. Next slide, please. So for the purposes of indicator development, we had to define health system resilience, very much aligned with the USAID definition. And it's essentially, let's keep things simple. It's essentially the ability to prepare for and respond to public health stressors and demands while maintaining essential health functions, public health functions, and in all contexts, importantly. And a key point that Nefra alluded to earlier is we need to learn and improve as we go along. So we define some functional capacities on the left-hand side of the screen, and on the right-hand side, we visually depict how resilience of the health system is built up over time in response to shocks and stresses. And the idea is that many different investments, both reactive and routine, build up the capacities of the health system, but we need quite intentional and integrated investments, as well as attention and design of health systems so that the baseline levels of performance and resilience increases over time and after each shock. You don't want to just be basically going back to your previous level of performance. You want to learn and improve, right? So, and then there has to be some legacy of the continual investments that are being made, whether that's from domestic taxpayers, from emergency and contingency funds, or from external aid and donors. Next slide, please. So next one, please. Thank you. So going into the indicators themselves. So our principles when developing this product was to ensure that we're not going to compete with other technical resources. Countries, subnational authorities, they're already overburdened with tools from the global level. And we wanted to ensure that this package is complementary from the get-go. So this package of health system resilience indicators both inform the development of and are completely aligned with existing monitoring and evaluation frameworks, which include the Primary Healthcare Monitor, MFI, the International Health Regulations Monitoring and Evaluation Framework, service availability and readiness assessments, health facility assessments, and universal health and preparedness reviews, and many, many others that I'm sure many colleagues are involved in. Here you can see the approach we've taken in the development of the indicators. I'm not going to spend too much time on this one, but essentially we conducted a scientific literature review underpinned by systematic methods, reviewed all existing authoritative databases and inventories of indicators within the scope of health system resilience capacities, health system building blocks, and from the health emergencies side. We also conducted expert consultations at national, regional, and global levels and conducted country pilots in Ethiopia and Liberia. This slide shows the results chain that we developed for the indicators, completely aligned with existing frameworks, like I mentioned, the PHC MFI. Generally, we can see that the health system building blocks indicators, those pertaining to health workforce, health financing, governance and leadership, health information systems, health infrastructure, essential health products, these tend to be structure and inputs. Service delivery, some governance indicators, and community engagement tend to be processes and outputs. Gradual improvements over time in these areas affect outcomes such as health service coverage to populations, equitable access to health services, financial protection, quality of services, and compliance with international health regulations. The desirable impact of all this, the key thing, is improved population health outcomes, so reductions in morbidity and mortality, as well as improved health and well-being. That's the kind of overall results chain and idea. So going into a bit of the detail here, for each of the 65 suggested indicators, we've been developing detailed technical specifications that can guide end users, and this is really the overall structure. We have the indicator name, the building blocks of the health system it pertains to, the definition and boundaries of the indicator, the rationale for measuring it, the suggested level or disaggregation of the data, and where applicable, there might be a numerator or a denominator, recommended data sources, and existing data collection tools that can be leveraged. Next slide, please. So time is a bit limited, so I'm just providing one example of one of the indicators. A very, very crucial first step in ensuring the maintenance of essential health services is to have a comprehensive package of health services focusing on both individual and population-based services, including those linked to other sectors. And we've defined a few criteria for this indicator. For example, the comprehensive nature of this package, that the package is aligned with national population health priorities determined by the countries, determined by the communities. The process for development has been in partnership with a wide range of stakeholders, including the community, and that the package is routinely updated as health needs evolve. This slide has more metadata and, for example, suggestions around a more qualitative assessment for gathering this information, and that often the information can be publicly available or may need to be found through certain parts of the Ministry of Health and partners. Next slide, please. This slide shows the illustrative targets that can help to understand the baseline and track progress over time. So for some countries or some subnational regions, they may not yet have an essential comprehensive package of health services. There are parts of DRC or other fragile, conflict and vulnerable states that don't have such a package defined. So over time, you may want to then build up that capacity, and you can track this in a non-prescriptive way. So some may have one that focuses on individual or hospital-based services, but has less population-based services like screening or vaccinations. There may be some that don't integrate health services across the life course or with disease-specific programs, and so on and so forth. Again, this is not a prescriptive thing, but it's for national authorities, obviously, to determine their targets. But it starts the conversation. Now, focusing a little bit on the application and how we envisage applying this resource in countries and how we've been doing so so far. A few key principles are on the left-hand side, and these are around feasibility and affordability of these of this data collection tool. We want things to be easily done, and we want them to be able to contextualize them to country needs. And lastly, you want to be able to integrate this with the routine health information system over time. Crucially, I'm not going to go through the whole cycle. It's non-prescriptive, but crucially, the information and data that we collect has to be bridged with policy and decision-making and implementation at service delivery levels. That's absolutely key. Next slide, please. This is a country example of how we've been applying this integrated package of support in Liberia, as well as other countries. On the left-hand side are a few of the additional things one has to do for health system resilience beyond measurement, though measurement is a key part of the overall resilience building process. So we also provide training, we improve quality of services, we do risk profiling and population health needs assessments, we support emergency management planning, providing health system-wide inputs into the health security process, we conduct simulation exercises and post-event reviews, and we share all this knowledge and best practices between countries and regions. On the right-hand side, I just want to emphasize the multi-sectoral nature of what we're trying to do in Liberia, where we map the key structures for public health. For health system resilience, there needs to be active partnership between health service delivery, the animal health sector, and the public health sector. And this can also be bring in the other sectors such as agriculture, food and nutrition, the humanitarian peace and development nexus, and so on. And all these interconnections need to be at the different levels of the system, at national level, country level, county level, district, and at the level of the clans and communities, depending on where we are. So coming to the end now, what are a few of our next steps? Well, we're finalizing the indicators package with USAID, countries, and partners. We're continuing to pilot in countries, adapting and implementing as we go. We're encouraging countries over time to integrate and expand the use of these indicators as part of their routine health information systems. And we want to use this information and data to communicate with decision makers, help countries to do that, national health authorities to do that, to ultimately improve the performance of the and resilience of the system. We're also exploring opportunities for collaboration in the rollout of this package. Next slide, please. So as we come to an end, I just want to leave you all with this thought that when health is affected, absolutely everything is affected. You can't have a resilient economy, you can't have a resilient environment, and you can't have a resilient society or community without health. Health, the environment, the economy, and social development are inexplicably linked. Also, the majority of the things that determine health lie outside of the health sector. So health is determined in the houses we live in, the natural environment where we breathe, the offices in which we work. So I would urge you all in the range of sectors represented here to think of health in all policies, health in all sectors. Health and health system resilience is everybody's business. Health is everybody's business, and without health, we can't solve climate change, war and conflict, humanitarian issues, food systems, AI-related issues, inflation and economic issues, and all the other currently unknown threats that are yet to come. So just a few questions for consideration on the screen, colleagues. What can and should be different in our ongoing and future collaborations to build resilience in health and allied systems? How can we streamline the measurement of resilience in health and allied sectors to maintain and improve public health? And the last one, what can we practically do as a group? Can we come up with a subgroup or some kind of mechanism to bring sustainability and impact in this work going forward, and ultimately for the communities that we all serve? So with that, thank you very much, and look forward to discussing further. Back to you, Nefra.
Thank you so much, Sakif. And what a compelling reminder at the end there that health and other sectors need to bring each other into each other's respective tents. We're going to transition now to our virtual colleagues from UNICEF, joining us from New York and Nairobi, respectively. While they are getting fired up on our screen, though, just a quick straw poll to understand where each of you are coming from, so to speak, in today's discussions. How many of you in the room and online consider yourselves to be working on or in the health sector or have done so in the past? Can I get a show of hands and maybe an indication from online? Okay, so maybe about a third of you in the room. We'll get the numbers from online in just a moment. Okay, all right. So we're going to transition now to our colleagues from UNICEF, Oscar Onam and Oscar Tapera, who are going to share experiences on advancing data systems for child health that flex or adapt according to different phases of the resilience cycle, so to speak. Dr. Oscar Onam works as a statistics and monitoring specialist with UNICEF's Division of Data, Analytics, Planning, and Monitoring in their New York headquarters office. There, he leads UNICEF's cross-sectoral global work on administrative data, supports country offices, including those in fragile and conflict-affected settings, and makes better use of administrative data systems to generate evidence on children. He holds a PhD in health systems from the University of Pretoria and master's degrees in both education and economics. Dr. Oscar Tapera works in Nairobi, Kenya, as an emergency specialist on humanitarian performance monitoring and information management in the Humanitarian Action, Resilience, and Peace Building section with UNICEF's Eastern and Southern Africa Region Office, or ISARO. He supports emergency preparedness, response, and resilience building, and leads on risk analysis, humanitarian performance monitoring, and information management for ISARO. He's also been leading UNICEF's Regional Data Readiness Initiative for the past 2 years. Oscar holds a PhD in health systems from the University of Pretoria and master's degrees in both development, biostatistics, and epidemiology, and program evaluation. With that, over to our UNICEF colleagues.
Thank you so much for the introduction. Can you hear me?
Yes, loud and clear, thank you.
Perfect. So we have around 12 minutes and we're going to share our presentation. We're going to split up a presentation into 2 halves. I'm going to present the first half and my colleague Oscar Tapera will present the second. So I'll be quick. The power of data in transforming our lives and the lives of children in development setting is profound. I have very little doubt that on this issue, I'm preaching to the choir here. So, but nonetheless, I decided to include this slide for emphasis, but I won't spend too much time on it, other than to stress on the opportunity that data gives us to count the overlooked children who tend to be marginalized, disadvantaged children that as an organization, UNICEF targets, like refugees, children living with disabilities, and girls. Next slide, please. So in humanitarian settings, data becomes even more critical in ensuring children's survival and thriving. It is for this reason that UNICEF supports national data for children that can flex. Being an organization that has a presence in more than 160 countries, with almost half of them in humanitarian settings, having the right data at the right time is important for decision making, for programming, for result monitoring, and advocacy globally. So what exactly is data that can flex? A national data system for children that has flex is one that is it is resilient enough to remain operational and secure. I think we've established the definition of resilient here. It's not different. How we define resilience is more or less the same how we had in the previous presentation. Another characteristics is they are responsive enough to provide information that is timely enough to help steer the response to shifting humanitarian needs. And the third one is they're able to scale up rapidly to meet new data needs and connect decision makers with the data they need to respond to changing community needs. And then finally, data systems that can flex they are open. So all actors at all levels within a country and outside have rapid access to that data to shape their response. When designing and using data systems that flex, there's usually a balance between the different dimensions of quality. We know here we talk about timeliness, relevance, and many others. And so finding that balance in an emergency setting is very, very critical. We know timeliness is key, but accuracy, relevance, representativeness, and cost also need to be taken into account. The ongoing efforts in UNICEF under the concept of data systems that flex could be grouped into three main categories. The efforts that we do before an emergency, during an emergency, and during the recovery phase. Increasing data access and integration are some of the efforts UNICEF is engaged in before emergency. And during emergency, we aim to work with what exists. For example, supporting countries to make the admin data system more adaptive and mobilize baseline data. This is where actually my focus area. In the recovery phase, the mindset to build back better usually guides us, which include integrating emergency data systems into regular long-term systems and reviewing lessons learned to strengthen data systems. Next slide. Thank you very much. Yes, so data systems for children that flex is proposed at this point in time is a proposal within UNICEF. And basically it's an umbrella that brings together all efforts, ongoing and planned within UNICEF that targets data system, that aims to strengthen the flexibility of national data systems in humanitarian settings. And these efforts could be looked at in a chart that you're seeing there. It could be broken down into the following proposed building blocks. The top blocks there you're seeing are on readiness. This includes efforts such as national planning process for disaster preparedness, which often includes communication channels and data sharing agreements and having anticipating data needs and many others. My colleague Oscar Tapera will talk more about that. The blocks in the middle are what we refer to as investments, baseline investments. These investments include providing support to build mature admin data systems and supporting household survey data. Here I'm referring to the support we give to MIX survey. If you're familiar with MIX, DHS, HMIS, and many others. The aim here is to have readily available data sources that could provide baseline data when an emergency hits. The bottom block represents the foundation. This includes efforts that ensure data governance structures and procedures are in place to collect, share, and use data responsibly. Here I'm talking in terms of safeguarding data protection and privacy. This block also includes making funds, talents, tools available to countries in emergency through a common fund within the United Nations. Next slide, please. So administrative data is critical to providing decision makers with the data they need to provide services and monitor development outcomes for children. There's no question about it. When data needs change, either due to changing community needs or sudden events such as an emergency, admin data systems also need to be able to change with them. Unfortunately, these systems are often slow, not very agile. So systems that do not flex are likely to be undermined. More often, we find that humanitarian partners, through the clusters, they end up developing parallel and alternative data sources, the result is usually they make the admin data system that existed in that country more unreliable. this may leave the country in a worse position data-wise than prior to the emergency. And so they're less able to provide the data required to support a return to a development footing. For that reason, building the maturity of admin data system is priority for UNICEF. Some years back, about 4 years back, UNICEF led the development and rollout of admin data maturity model. The model goes by the acronym ADAM. ADAM basically it provides country with a framework to benchmark their admin data landscape for children through a cross-sectoral lens. Not only health, but all the sectors that we know are relevant to children, that is education and nutrition and many others, civil registration and vital statistics and many others. And so it helps countries to assess how admin data delivers for children at the individual level, at the community level, and at the national levels. ADAM also helps countries to identify gaps within their admin data systems and investments also, which then can also be prioritized for greater impact. I mentioned earlier that the tool adopts a cross-sectoral approach, and the idea behind this is to promote cross-sectoral linkages in the development and implementation of a data strategy later on. The tool complements existing sectoral assessments. We know there are quite a number of them that exist in the health sector and many other sectors. So far, UNICEF has supported 5 countries to utilize the tool to assess their data system. That is Namibia, Oman, Liberia, Bangladesh, and Nepal. Oman used it to assess the nutrition registers. Bangladesh and Nepal used the tool to assess their health information system. And Liberia used it to assess a number of sectors, including health. In Bangladesh and Nepal,
Sorry, Oscar, just to note, 4 minutes. 4 minutes, please. Thank you.
Okay, thanks. Thanks for the reminder. In Nepal and Bangladesh, they use it to assess and document the practices that contributed to their admin data systems flexibility, resilience, and responsiveness during the COVID-19 pandemic. And in the process, they identified gaps that they are prioritizing now to improve those data systems. Next slide, please. So from these assessments, we had a number of lessons that we learned. I'm not gonna go through all that because of time, but one big one is the public-private partnerships that existed in these 2 countries played a crucial role in supporting data systems during the pandemic. That partnership leveraged the resources, expertise, and innovation in both sectors, private and public, that enhanced data collection, analysis, reporting, and that ultimately enabling more effective decision-making and response efforts. I will hand over the rest of the presentation to my colleague, Oscar Tapera.
Okay, thank you very much, colleagues, and thank you, Oscar. I'll try to run through this. I think we have a few minutes. Next slide, please. So, colleagues, I just wanted to as well on what my colleague has been mentioning about admin data systems. So in the Eastern and Southern Africa region, about four years ago, we piloting an approach to strengthen country-level preparedness by utilizing and strengthening, a sub-national level data. And our entry point was emergency preparedness, and we are now in the space of even influencing response planning. We started off with 6 countries, some in the Horn of Africa, but a few in the Southern Africa. But to date, we now have 8 countries, including all the drought-prone countries in the Horn of Africa, and as well as some countries in the Southern Africa. So what we are seeing here, particularly on health, is we're able to do some risk analysis or hotspot mapping for cholera in Kenya. As you know, that Kenya is also struggling with responding to a cholera crisis this year. And one of the things that we have been able to do was to utilize historical data and mapping out the hotspot areas using the data readiness approach. But the second use case as well, which we have also seen very critical, to Kenya, in addition to, of course, the Horn of Africa drought response, which we know is also driving the cholera outbreaks. We've also seen that there are cross-border, hotspots, which are very key for country offices, particularly cross-country or cross-border coordination. As you know, cholera does not know borders. So one of the things that we've also been using this data readiness initiative, is to ensure that there is cross-border coordination, but also preparedness actions can be enhanced across the borders. Next slide, please. Zeroing in on Somalia, we've also done hotspot mapping for cholera, but also for measles cases in Somalia. And the maps that you are seeing here, you're looking at the first one, you're looking at the cholera cases, the actual numbers by district, and this is actually from last year and this year. We also have IDPs, the IDP sites. As you know, Somalia has also a very high IDP site, population, and you're actually seeing the cases or the incidence of cholera cases in IDP camps, and of course. What we are seeing here is a heat map which shows severity or where there are high cases and where there are lower cases, and this has been helpful for our country office to respond better in terms of preparedness actions, but also where the gaps could be, particularly in WASH health and social and behavior change, which is an area of our which are areas of our accountability. The other one is measles. As you know, in addition to the cholera outbreaks, drought also drives measles cases, and where we see drought, there tends to be higher risks for measles. And in Somalia, we've seen increases in the cases of measles, and the map that's on the far right is showing the cases that were mapped out using the data readiness platform, and the map has been used by colleagues to actually inform campaigns, measles campaigns, vaccination campaigns, but also other services that we, or interventions that we provide as UNICEF. Next. The last one, which I picked, is also the malaria, cholera preparedness Malawi, cholera preparedness in Malawi. As you know, since 2022, Malawi has been facing a very high and deep and protracted cholera crisis, which started early last year, and the driver of that cholera outbreak was actually the tropical cyclone Ana, which hit Malawi around January 2022. So what you are seeing here are two maps, which are our risk map. The very basic and qualitative, the left one is the qualitative one, which is showing our flood hotspots, but on the right, you're actually seeing the map of cases. So what we have been seeing is we have seen a correlation. As we know in literature, there is correlation between flooding as well as cholera. And what we have tried to do was to validate our thinking and also our preparedness actions, that where we have got cholera, where we've got floods, we're likely to tend to have cholera within the short space of time. And these two maps have actually validated that, and the country office have used this kind of maps to inform their preparedness action, and also prioritizing the flood hotspot areas for cholera prevention. We know that the cholera has been reported. The cholera cases have been reported across the country in all districts. But what we know is that where the floods, where we have got flood hotspots, there are also cholera hotspots. So our preparedness actions have been strengthened and therefore have been scaled up to ensure that we can contain the cholera outbreak. And I can safely say that at this point, the cholera cases in Malawi are going down, and of course this is a contribution of multiple partners, including our health, WASH, and SBC teams that have been working with the country office team. So colleagues, this is just a few examples of how we are using admin data, subnational level data to enhance preparedness, but also response for public health emergencies. Thank you, and back to you.
Thank you so much, Oscar. And Oscar, I think that was a sprinting marathon, to say the least. Yes, let's give them a round of applause. And what powerful examples that serve as important reminders for the need for all hazards approaches. I'm going to take you next to the Democratic Republic of Congo, or DRC, where the USAID Bureau for Global Health supported Momentum Integrated Health Resilience, or MIHR team, has been adapting the recurrent monitoring survey methodology for health programming needs. Speaking to this will be Dr. Cougar Hall, professor in the Department of Public Health at Brigham Young University, or BYU, where he teaches undergraduate courses in health education and promotion. Cougar has worked with Chorus International, or IMA World Health, on maternal and child health nutrition projects, in Indonesia and Tanzania. He's also part of the BYU team working with MIHR on health resilience in the DRC. Cougar holds both a PhD and Master of Science from the University of Utah. Cougar, over to you.
Thanks, Nefra. And that's a good looking picture. They must have photoshopped that. You're looking at the real me, and no, I'm teasing. Yeah, let's go next slide. And you've already given us great definitions of health resilience, and you've explained MER, but I should probably touch on a couple of those things. So MER, Momentum Integrated Health Resilience, we're working in fragile settings in 8 different countries. Today, in this presentation, we're just going to talk about what we're planning to do in the DRC. And this is really our health focus. So family planning, reproductive health, maternal, newborn, and child health, and also nutrition. So as we get to what we're really looking at in the RMS, we'll come back to our charge there as a program. We have many great partners, a few of our partners here in the audience today, and I'll introduce them as we get there. So let's go to the next slide, though. So the first question is, why the DRC? And then the second question will be, why an RMS? And the DRC, I think yesterday someone said, shocks are the new normal. And I think if you look at it in the context of the DRC, I don't know that shocks are the new normal. I think they've been the normal for quite a while. So many opportunities here to address the health needs that MER's looking at. But I think maybe what's most important on this slide, because I think you're aware of the history of shocks in this region, but I think what really caused us to focus on the DRC and choose the DRC from these 8 other nations that MER's working with is just really strong partners in this area. And as you know, you can have the grandest of ambitions, but if you don't have people on the ground with the technical skills and the know-how, you're not going to get anything done. So that's really why we chose the DRC, and in particular, we chose the North Kivu region. You can see we have health zones and facilities there in abundance. So we're excited about that. Next slide. A little bit of the details on this. So I just mentioned we'll be in the North Kivu region, 64 different communities. In each community, 25 households. If you do the math, we're about 1,600 is our sample size. We're anticipating some attrition at about maybe 20%. So I think our in total goal is approximately 1,300 households in this study. Inclusion criteria is that they have a newborn under the age of 1 year or 12 months. Next slide. So this is the definition that you read for us from the beginning. It only varies slightly from the general resilience definition. But if I can just point out again where it says reducing acute and chronic vulnerabilities and also equitable health outcomes, I think that's where we're pivoting a little bit. And we're really excited to do this. I know the definition's been out there for a little bit, but we're building on the shoulders of giants in the field of resilience, and in particular the giants that have done RMS methodology and we're just making some tweaks here and there. It may be that resilience is resilience, but we really believe in our hearts that there's something that's unique about health and health resilience. If I can just say, shocks always impact health. Health shocks impact everything we do at the household level for sure. So, okay, next slide. So MER is working at 3 different levels here. And maybe if you'll click it 3 times in a row, is that okay? We had one of those transitions where we have the RMS and yeah. Oh, and now let's go back one. Thanks, Nefra, sorry. So just a little bit of a plug for MER, and this really goes along with what Oscar and Oscar were saying, and also WHO. You did such a good job explaining what we're doing in those areas. But as far as health systems and health service, we are mainly using modeling and mapping to do that. And Isabel back there, wave your hand. Isabel, she has the most incredible diagram and poster if you want to look at what we're doing for health service and health systems. And we've done that in South Sudan and in Niger. And then we also have the ARC-D, which is at the community level. This is mainly using focus groups. We have 29 different components that we're measuring on a scale of 1 to 5. And it is pretty straightforward, but really using that qualitative approach. And we've been doing that South Sudan, Niger, also Burkina Faso, and Mali. Yeah, so, and then the RMS, which is at the individual and household level, and that's what we're doing in the DRC. So we feel like MER is covering a lot of that. If you happen to be before lunch in the session with Jill from Mercy Corps, the whole RMS approach was explained really well. We've placed here that this is a household survey and it's triggered or initiated by a shock. We are not waiting for a volcano to erupt. We're not waiting for the next pandemic. We're launching this as soon as we can and just anticipating that of these 1,600 households, there's going to be a fair number, a vast majority that are experiencing some shock at some level. So yeah, I think everything else is straightforward here. We're going to get some data on health outcomes and how those are affected by shocks. We're going to use a panel or a cohort. We're going to follow those same families over the course of approximately 12 months for data collection rounds. Next one, Nefra, thanks. So why a health RMS in particular? Again, looking at the nature of shocks, the impact of shocks on health outcomes may or may not be unique, but we anticipate that they will. So that's certainly our hypothesis. Again, how households cope with shocks. And this is what we're all looking for, is what is the trajectory? So how are they able to not just bounce back, but improve or unfortunately collapse on the other side of that? I actually have 3 slides here in Nefra that are all really similar and that feel like we're covering the same ground as before. Maybe what I can point out just a couple bullet points here. We've heard this multiple times over the last day and a half. The frequency of data collection allows for incremental learning and adaptive management. I think that's our goal, right? Whenever we have a program, we have a 5-year program, we would like to gather data every 4 hours so that we can pivot and we can adapt, and we don't have to wait till end line and then say, oh, if we had known this 3 years ago, we could have really made some hay. That's our goal, but I really think we should mention, because this is the guinea pig of health resilience in so many ways. We're also looking for basic knowledge, and I can speak for most of the team in saying we don't know exactly what our blind spots are, but we know that there are many, and we're really putting forth our best effort, building upon previous RMS work and previous resilience work. But there's an element of this that's not just going to be able to adapt our programs and pivot mid-cycle, but it's also, we'd like to start to gather information on this topic or this concept of health resilience. So that's a lot of talking. I think that's what I want to say here, though, is are there unique coping strategies? Are there health shocks that really do trigger, just other challenges for a family or for a household down the line that again are unique to health, that may vary from environmental and from financial shocks that we've studied a little bit. Okay. Just a nice diagram to show the way we're hoping that this rolls out. We have a baseline. I think we have 10 modules in our baseline. When we did some pilot testing with this on campus at the university, it took a little over an hour. When we had the DRC team do it, it took approximately an hour. So it takes a fair amount of time to get through the baseline. And you can see we have 3 RMSs approximately 3 months apart. And those in pilot testing took about 45 minutes. I mentioned that because we're going to get to the challenges, and that is the primary challenge, is length. We don't want the enumerators to become, the largest household shock. We're knocking on your door again. That's the shock, right? Very well could be that. Our data collection approach is face-to-face, and enumerators will have a tablet, and we're actually, as you might be wondering where we're at right now, because we haven't done this yet. Right now, we're working with JSI to digitalize the survey, to put it into the CommCare platform. I'm just about done with that. It's pretty smooth, but if you've done an RMS, you know that it is skip pattern heck. So they're working hard to get that done, but it'll be face-to-face. All right. Oh, I forgot to hit start, but you'll tell me when I'm out of time, I hope. Okay. So this is really what I want to talk about, because until this point, that's probably all old news for you. But I really want to get into, and as we get into our cafe session here, this is where we need your help. And I'm not just saying that, that's not pseudo-humility, but we need your help as far as help us understand what we don't know. But this is the baseline. You can see we have 10 modules. We have primarily ripped off our friends at Tango. So thank you, Tom and Tim. Some of the things we've borrowed from Grameen. The BYU team did a very nice project several years ago looking at resilience and women's empowerment. It looked at agriculture and livelihood. It was in Burkina Faso. And so because we have those relationships, we just took some of the modules, the demographic type stuff from them. But really, we've looked at previous RMS. We have the PREG 2. Do have some mix. Oscar just mentioned the mix and the DHS. We have some modules that we've taken from there. I think maybe the things that are different on the baseline that we don't see maybe in the other RMSs, we do have just a really short section, just 6 items on individual resilience. It's called the Brief Resiliency Scale. So we hadn't seen that one used. And then because we're total health geeks at the university, at least, we love the theory of planned behavior, this idea of attitudes and beliefs and social and subjective norms and perceived behavioral control, which is a fancy way of saying self-efficacy, in my opinion. But we included, and it's about 15 items here on knowledge, attitudes, perceptions, and practice. We'd really like to get the RMS data and come back and layer that over some of those self-reported attitudes, perceptions, and practices. I think everything else is pretty standard. Let's jump to the next slide and look at where we're really jumping head first into the deep end. You can see now we have modules 11 through 18. And I really want your feedback here. We have taken this first, which is just general shocks, and we have followed the format from previous RMSs. And it goes something like this. There's generally like 4 questions. It'll generally say, which of the following shocks has your household experienced in the last 3 months? And then how many times did you experience that shock? And what was the impact? And what did you do? That's loosely how we tackle that section in other RMSs. We added 1 question, so instead of 4, there's 5. And it's how did that shock impact your household health? So that's one tweak there. But then module 12 is completely different. And again, we've borrowed and ripped off other items, but this is specifically looking at health shocks. And I'll walk you through what those health shocks might be. But this is completely new. And then we have a list of coping strategies that we anticipate they may have used to deal with those health shocks. Sorry, one more. Kind of excited about this. I think these are all pretty standard, because we're looking at maternal health, and we have maternal diet, food security. We're looking at child nutrition and health. We selected diarrhea as the largest childhood health indicator, and contraception. But I think this is kind of a cool one here. We found a study that came, I forget where it was done, I apologize, but it was looking at COVID-19 and interruptions to health services. So because of COVID, did this interrupt your ability to get your child immunized or deworming or antenatal or postnatal care? We really like the way they set up those questions, and so we added some of that here to our health and accessing care. Okay, sorry. Go ahead, Nefra. Okay, our health shocks, our illness, and it's your spouse, it's yourself, it's your child, anyone else in your household, or anyone that your household feels responsible for. And injury and food insecurity, food prices, pregnancy, unplanned, unintentional pregnancy, a loss of a pregnancy, and a violence, especially gender-based violence. On a personal note, I think I have probably 10 seconds to share this. As we've been developing this survey and actually preparing for this presentation, I crashed on my mountain bike and I broke my wrist. I just got the cast up before I got on the plane. So if you see me massaging, you're like, he really likes to touch his wrist. It's still swollen, it still hurts. But I think all of this was hypothetical for me. I come from tremendous privilege. And I broke my wrist, it's in a cast. I'm getting emotional, that's silly, but you should see what was supposed to be my garden. It's knee-high in weeds. Haven't mown my lawn. Just there's so many things that were neglected. And I've been typing with one finger, and so my productivity at the university has waned a little bit. But nothing. I've probably every day I've thought, what if agriculture was my livelihood? What would I do? And I don't know that there's a lot of social safety nets in the regions where MERS working when it comes to something like this. So as silly as I thought this was, like injury, now I had this aha moment. We're talking about aha moments this morning. That was one hit me right between the eyes. So things that are inconvenient for me would be a tremendous shock for my household otherwise. So anyway. I digress. Now back on track. So we have really struggled. It's taken way too long to put this questionnaire together, this survey together. But we have some general things that we've included, some cost and some access to health services. Again, interruption to those health services. We had to look at maternal newborn child health. So we have maternal diet, breastfeeding, dietary diversity. We labored back and forth, argued, if you will, between diarrhea and fever, and we opted with diarrhea. We felt it was less subjective and we might see it more often. Reproductive health, family planning, lots of questions about contraception, access to contraception, decision-making in the household as far as contraception goes. And then nutrition, really standard measures that we like this because this is the bridge between a health resilience RMS and previous RMSs, looking at livelihood, looking at agriculture, because we're using the same scales, food security, maternal diet. The other, we as a team, we prioritized what are the other things we'd love to know. And as a health nerd, I'm always thinking, what happens when you experience a shock or a stress? Well, your endocrine system goes bonkers. We have the sympathetic nervous system it's cortisol, adrenaline, and that absolutely, we've evolved to handle 30-second to 3-minute shocks. And that's not the way the world works now, especially in the DRC. So what are we doing to literally every body system? And that's a driver of, in my opinion, all chronic disease, and really impacts infectious disease because it downregulates our immune system immediately. So not to get too much into those weeds, but we really wanted to look at what are some of the psychosocial indicators that we could pepper in here if we had room, right? We didn't have room. But social support, social capital, life satisfaction, confidence to adapt, and some gender norms decision-making. Those made the list. So there's not as much as we wanted, but we have a few items in each of those areas. And then we had a hard stop. So we had scales on altruism, WASH still is in there because there's some demographic things on WASH as far as infrastructure and hand washing, but we had way more we could have put in on WASH that unfortunately got left by the wayside. Mental and emotional health, we felt like that should be there and it got cut. Sleep, locus of control, anxiety, even personality, interesting stuff. So interesting things out there on conscientiousness that we thought, man, we'd love to explore that. That all went by the wayside because of the challenge of length. And we just can't sit down with a mother for 3 hours and say, okay, we'll see you again in 12 weeks. So I think that's about it. What's next? I'm sure my time is up. So as we break into discussions in a moment, how can we use this data? Is this a tool that you think we could adapt and improve upon? Your experience with RMS, we would love, I mean, for the BYU team, this is our maiden voyage. And how can we broadly, not just with MER, turn this data into action? Why health resilience? Do you think we've made up this concept, or is this something that you think we should explore? And the best measures, and how can we address challenges related to the length and the cost? This is an incredibly expensive endeavor, and that's it. Thank you for your time.
Thank you so much, Cougar. So compelling. And, you know, I was remiss in the beginning. I'm going to mix metaphors here for a moment. But I said we're building the plane as we're flying it. But we are, as you noted, also standing on the shoulders of giants, largely from the food assistance and food security sectors. You know, MIHR collaborated with the Resilience Evaluation Analysis and Learning Project, or the REAL project, to even get them started. There was no point in starting from zero. Why not capitalize on the tremendous expertise and experience of our colleagues from Save the Children, Tango, and others who have long since been working on the recurrent monitoring survey methodology. Another thing that excites me about this work is that this is our first known adaptation of the RMS methodology, primarily for health programming purposes. If there is anyone else in the room, or for among the 50 or so colleagues online that has also been working on this, please, we really want to hear from you. We want to know, we want to learn from you, and we want to learn together. I also really love how you described nutrition as the bridge between the perhaps more, you know, traditional RMS methodology and the kinds of data points that were collected. Nutrition and WASH, I think, holds true for that statement as well. And that, I think, is the perfect segue to our last presenter. So hold on to your questions and comments. We are almost to the discussion portion. We're going to hear about a topic that's likely familiar to many of us, but that's arguably received insufficient attention, specifically in terms of health sector and health systems considerations. Integrating nutrition into resilience capacity building approaches, measurement, analysis, and evaluation. Joining us remotely to ignite a discussion on this topic on behalf of the Resilience Evaluation, Analysis, and Learning, or REAL Award, funded through USAID's Bureau for Resilience and Food Security, is Dr. Nancy Mock. Nancy is Associate Professor in the School of Public Health and Tropical Medicine at Tulane University, where she's held a variety of academic and leadership positions since 1986. She served as Country Director of Tulane's Research and Education Programs in Rwanda. From 2009 to 2014, she served as founding co-director and co-creator of the Disaster Resilience Leadership Academy. She now serves in advisory roles to numerous expert groups on resilience measurement and has contributed to more than 100 peer-reviewed publications and technical reports. Prior to joining Tulane's faculty, she served as field director and co-creator of the famine early warning system that many of us now know as FuseNet. Give me a person who has not heard of FuseNet. That's pretty remarkable. Nancy holds a Doctor of Public Health, or DRPH, from Tulane University and a Bachelor of Science in Biology from Yale University. Nancy, over to you.
Great. Good afternoon, everyone. I'm really sorry I can't be there in person, but you can see I'm in a lovely place. This is a backdrop of my little cabin in Wyoming. So I'm not badly off, but I wish I was with you all. Today, we in this presentation, this notion of nutrition and the centrality of nutrition in the resilience discussion is really what's going to be highlighted here, as well as, what can we do to be effective through health sector interventions to achieve nutrition, and I'm going to coin the term nutrition resilience. So today will be, next slide, please. And next slide, we talked about real. So we'll be looking at the sort of the conceptual framework linking resilience and nutrition, the implications for health sector strengthening or health sector development. We'll go over one case study and then some research needs. What I'd like to say is that this work builds on a discussion brief that a colleague of mine, Joan Jennings, who's on the line, and myself developed over a year ago. That really focuses on how do we better integrate nutrition into the resilience movement. And the key messages that I will come back to throughout this presentation are that, one, anticipatory surge capacity for health threats and threats to nutrition is one of the very, very important things. We've seen throughout this session that there's a lot of soul searching within the health sectors. How do we really rise to the occasion of addressing these shocks and stresses? Anticipatory surge capacity is crucial. And so that'll be message number one. Message number two is coordination and engagement with other sectors so that we effectively sequence, layer, and integrate interventions from multiple sectors to address the problem of malnutrition. And thirdly, that we advocate for nutrition information to be mainstreamed in resilience measurement systems. Just a moment ago, Cougar mentioned that nutritional variables were going to be collected. But for example, anthropometry wasn't mentioned. Anthropometry identifies one of the key indicators of humanitarian stress, which is global acute malnutrition. When kids are thin and adults are thin, they are at greater risk of mortality. And so this is one of our key indicators of vulnerability to shocks and stresses. So let's keep this in mind as we go through in identifying measurement issues. Next, please. I think we can skip this one as well. So going back to complementing and building on the work of others, this is the USAID framework for resilience that was developed by Tim Frankenberger and colleagues. What we've done in the discussion brief is to identify how nutrition fits into this. And you can see in terms of context, malnutrition is a very important variable, but well-being outcomes, nutritional status, and the dietary and immediate determinants of nutrition are very important well-being outcomes. Yet they're often not measured. And as we look through the framework, we see that in terms of capacities, the ability at the level of human capital assets, the caretaker competence, the ability to make decisions with respect to shocks and stresses is critical. And we believe also household monitoring, the ability of caretakers to actually understand the nutritional status of their children and to be able to have a gauge on that. We've paid much too little attention to this notion of giving mothers and caretakers the capacity to evaluate what's going on with respect to nutritional status and to make decisions to deal with that in the context of shocks and stresses. Structures, so scalable community management of acute malnutrition. This is a capacity, a very important capacity that we'll see in a case study probably contributed to mortality reduction in the drylands of Kenya. And then strategies that are important with respect to nutrition sensitive and specific interventions. Next, please. Great. So we, in the paper, develop a pathway diagram building on UNICEF's conceptual framework for explaining malnutrition and mortality. The key thing that I think everybody's emphasized in this conference is the importance of looking at nutrition and the various structures that influence nutrition from the perspective of shocks and stresses. And this is really what's different about resilience, or makes it different than our typical development concerns. So the real issue here is really planning with that context in mind. Next, please. And one of the things that many have mentioned is that nutrition is influenced by so many factors. And one good case is, how nutrition was influenced by the pandemic, and how we actually, as health sector experts, underestimated the impact of COVID-19 on nutrition, not only the direct impacts of the disease itself, but importantly, the indirect effects of the lockdowns and our approach to dealing with the pandemic, which actually had a larger effect and a larger negative impact on nutrition than did the disease itself. Next, please. And in terms of our thinking about how to deal with something as multisectoral as the problem of nutrition, very important is this humanitarian development peace coherence, or portfolio approaches to addressing the problem. We have to be clever. We have to be looking at ways to more efficiently focus resources on vulnerable populations. Key to this will be, again, sequencing, layering, and integrating to ensure sustainable nutritional improvement, and preparing to scale up nutrition-specific interventions, especially CMAM, in anticipation of shocks and stresses. And here, I think the key point is in anticipation of, CMAM has been used to respond or to manage crises, but the important need is really to anticipate and preposition so that early malnutrition can actually be addressed, so that moderate acute malnutrition can be addressed. Next, please. So implications for health system strengthening. First, anticipatory surge capacity. This is so critical, and we're going to see a country case where this is actually starting to occur and starting to be managed by country government. But it's surge capacity of the health system in general. We know COVID is a good example where that was needed and where that was not possible to achieve. The community management of acute malnutrition, or integrated management of acute malnutrition surge, where persistent acute malnutrition is a feature, and or high levels of stunting. So we do know that where you have high levels of malnutrition, in a quote normal context, the deterioration of populations to famine and severe food insecurity happens very quickly. So we need to be able to surge. In some countries, it is still at the crisis management level that is responding kind of late. But in some situations, we are now getting ahead of the game, and that is this anticipatory idea. Surging based on good early warning information with early action thresholds and such to move resources, human and material resources, around to areas that are likely to have need. And then the government capacity to manage this. That's also critical. And then coordinating all partners around common surge policies, because there are so many partners who are involved in service delivery And finally, strengthening the capacity for nutrition counseling at all levels. We'll find that integration of nutrition counseling and social behavioral change strategies, integration is really quite important. Next, please. Implications, again, sequencing, layering, and integrating this really, flexible use of tools and of different instruments that donors and governments have. So very important is to coordinate and layer and integrate nutrition initiatives from the health sector with other resilience strengthening initiatives. And here, integrating mainstreaming nutrition behavioral change with savings groups and other livelihood interventions. There was a reluctance to do that early on with the fear of overloading, over programming savings groups. But what we're finding is savings groups are a tremendous hub of energy where it's, with the availability of resources that are generated through savings groups, women and caretakers have the ability to make behavioral changes. So these kinds of linkages are quite important. Advocate for nutritional vulnerability as targeting criteria for social protection and safety net programs. So safety nets are becoming a very, very large part of resilience, the resilience push, national safety net programs, and ones that are often decentralized. But nutritional vulnerability is not always or consistently considered when targeting these programs. And that needs to change. And then to layer, integrate nutritional behavioral change with safety net programs. And then please, we can go on to the next. Very important, nutrition information. Measure and monitor nutritional status in the face of shocks and stresses, including anthropometry as well as dietary indicators. Incorporate routine nutrition information and early warning, early action systems, and then systematically monitor nutritional outcomes when evaluating shock response. And then you'll see that we need to, better use this information as well, analyses that link nutrition to coping behaviors. Next, please. I'm going to just briefly highlight the progress that has really been made to drive down mortality, and including nutritional interventions as an approach. Next, we can go to, this is Kenya. That USAID has very cleverly coordinated portfolio management of food insecurity and malnutrition in the drylands of Kenya. And it has partnered with UNICEF and other NGOs to really see that this community management of acute malnutrition surge is routinized in the government of Kenya. But this is also complemented with other types of resilience interventions. Next, please. Research needs. There's a lot to do to understand better how we can respond to the problem of malnutrition and through the health sector. And one is looking at the nutritional, basically which package of interventions gives us the biggest bang in terms of improving nutrition. And so this is a very key issue that needs to be addressed. And then is resilience, and if we're really successful at building the front end of resilience initiatives to improve livelihood and to strengthen routine health systems, can we then avoid the need for surge capacity, particularly with dealing with acute malnutrition? Next. And here are the questions that we want to ask in the cafe.
Thank you so much, Nancy. Let's give her a round of applause. We have about 25 minutes left remaining in this session, believe it or not. And so in the spirit of adaptive management, we're actually going to facilitate the discussion in plenary with participation both from our 50 or so online colleagues and from our colleagues in the room. Before we do that, though, I'm going to I'm going to hop off my stool here and shake it out a little bit. I'm going to encourage everyone in the room to do the same. Cougar, don't shake your wrist out too hard, please. All right, great. So while you're stretching and shaking it out for those in the room, perhaps also online, why don't we move now to comments and questions? What I'd like to ask of anyone who would like to address a comment or question is to please aim to be succinct. So just one comment or question to start with, and we'll come back to you as time allows. Provide your name and affiliation, and be clear on whom your comment or question is directed to. With that, also in the name of equity, let's see if there are any comments or questions from our online colleagues to start. And those in the room, you can sit down if you like. It's really up to you. Thanks. All right. Anything from our online colleagues so far? If not, we can start. Oh, yeah, we can start with questions or comments from the room. Please.
Thank you. I know I'm already going to break your rules because I'm not actually sure who should answer my question, and I'm hoping that the people who know more than me, being the people answering, will decide for me. I wanted to make a brief comment and also ask a question. My name is Stephanie, and I am very rare at this conference in that I'm actually still a student. I am doing my master's in climate change and sustainable development at the University of Cape Town through the Africa Climate Development Initiative. So I come here with a climate agenda and mostly to learn. And that being said, my undergraduate is actually in anthropology, so I'm secretly a social scientist in disguise in the science faculty, which is quite a journey. And I wanted to comment that perhaps employ more anthropologists and involve more social scientists. I think that's not news to anybody, but I suppose I just wanted to advocate for that further because I think that the social sciences and anthropology in particular are a really important disciplinary mechanism for avoiding maladaptation and avoiding the problem of having great intentions and missing occlusions and blind spots, especially when we're talking about ontologies, attitudes, values, communities, even with things like figuring out how to work through things like values, attitudes, like conscientiousness and personality. And my question is about how to change people's minds in terms of understanding that when we're talking about justice and we're talking about distributional justice, we're also talking about how climate change is currently resulting in loss of life and debility and morbidity, mostly in, you know, the most vulnerable, marginalized and impoverished parts of the world. And I think that for me, it's been actually, in the spirit of vulnerability, very upsetting that in the spaces I've been moving in, especially in a youth academia place around climate change, I don't really see the conversation ever being about how climate change is a health problem and that both of those things are problems of equity and justice. And I would love to know how to fix that from where I'm standing.
Thank you so much for those thoughtful comments and question on the need to integrate climate change considerations and climate mitigation and adaptation into health sector programming. Would any of our colleagues in the room or online like to venture a reaction?
Thanks very much. It's a really excellent question, and I think there's a number of things I want to kind of touch on that. But maybe first to say that the big thing that I think we want to get across is that the unit of action, the unit of action has to be building capacities within national capacities, national health systems to be able to respond to climate change, economic stressors, infectious disease outbreaks, routine and less sexy things as well, like non-communicable diseases. So it's about building inherent capacities throughout. And within that, yes, we absolutely need more incorporation of climate-related health issues. And I am, you're preaching to the choir here. Absolutely agree that climate-related health threats, overheating, the fatigue and everything that comes with that, the relationship in terms of seasonal outbreaks that comes with that, absolutely integral. Like that is absolutely key. So as part of what we're doing to address that is taking this all hazards approach to these indicators, to the work that we do, to the guidance that we're providing. Countries typically have an emergency preparedness and response plan. They have a climate response plan in some places. They have a national action plan for health security. They have antimicrobial resistance plans. They've got all these different plans, but ultimately all of these need to link back to the National Health Sector Strategic Plan. And actually that also needs to feed into other sectors like the Disaster Risk Management Committee or whatever equivalent up to cabinet level. And that's one thing we are all as a community, whether it's health, development, nutrition, climate change, we're all very good at speaking within our bubbles. But what we're not so good at doing is convincing the finance minister, convincing the private sector, convincing other line ministries about this need to come together, and that all of these are ultimately desirable actions, cost-effective actions, to ensure that the economy runs smoothly, to ensure that people are doing their best, that they can contribute to taxes and keep our society running, essentially, right? So that's something I would, turn it back to you guys. You guys, I was in your kind of position 5-10 years ago, and we have to agitate. We have to do things a bit differently. We have to be more noisy, annoying, whatever, and we just need to keep being persistent. And then the point on the social science one, I think is so key. Just one example around COVID-19 and risk communication, adherence to public health measures. How essential is that we understand the people that we are giving this advice to, understand their context, understand their lived experiences. Like, of course, it sounds like a no-brainer, but it's not being done. So you're absolutely right. We do need to do that. And then that has transferable utility and benefits in terms of some of the other things that we're currently facing: misinformation, disinformation, artificial intelligence. Yes, there's going to be huge benefits to that. There's also some unknowns that we have around that. And those same behavioral change elements and capacities that we build up within national health systems, that can be utilized, pivoted for climate change, climate health related threats and other stuff. So it's, completely agree with you. I don't know if it answered your questions, a few unstructured thoughts, but it'd be good to hear from others as well. Thanks, and back to you.
Thanks so much, Sakif. Any contributions from our UNICEF colleagues or Nancy before we move to the next question? Thank you. And I think just a final contribution, I think, we've talked a lot about bringing health and other sectors into each other's tents. I think one example of that from the non-health sector perspective is urban planning. When we consider the growing trends in urbanization and the need for very intentional urban planning, and to take all hazards approaches to urban planning and risk and vulnerability mapping, and considering the needs of, informal urban settlements, for example, those hazards that could have health impacts also need to be considered. And I think oftentimes health sector stakeholders are just not part of those discussions or planning processes or costed strategies or coordination and technical advisory structures. So I think the advocacy goes in many directions. We have a question from online. I'm going to give the mic to my colleague Nate to share it.
Thanks, Nefra. Yeah, so we actually have a comment from Joan Jennings, who said that Dr. Mustafa's statement about the healthier a population is going into a pandemic, the healthier the population will be coming out is super important. And, just aligning with that. So she's a senior advisor, a nutrition advisor at Save the Children. And for her, good nutrition status equals good health. So we have a question from Jennifer Cisse, who is from Apt Associates and formerly from USAID. So this is for Cougar. And she wanted to ask, she's curious if you had considered for the follow-on surveys, whether you would randomize who might get which modules in order to allow some time and space to dive into those additional questions that you might have cut e.g. on sleep and on mental and emotional health. Yeah.
We did not. Sorry. It's a really good suggestion. We kept the one size. Analyze the data on the back end. And I think sometimes one of the frustrations if you're analyzing the data is that, oh, they switched things up at midline. And so indicators don't match up and we can't use any of this because we can't look at three different. I don't know if that's the reason. It might just be we don't know what we don't know, but it's a really strong suggestion. I actually have my two colleagues from BYU. Do you want to address that at all? As to why we don't randomize? So we could have a A and a B as far as an RMS, and we could randomize that and address more of those psychosocial indicators. I don't know. Yeah.
Thanks, Cougar. I think a couple reasons. One is we have our sample sizes powered to be able to detect differences in some of our key indicators. So if we randomly then did some additional modules, which is a really interesting idea, we could elicit some other data that would be interesting, but then it would be far less powered to do larger analyses with. So kind of pros and cons. So we kept it pretty standardized and kind of kept a concrete set that everybody did the same thing. I could see real value in that if we were taking some different analytical approaches or pilot testing or trying to do some other things with it.
Thanks both. A very provocative question. Thank you. I think, yes.
Hi, thank you so much. My name is Ibrahim Bahari, and I work as a senior research fellow for the Human Sciences Research Council. My question will go, I think, to the UNICEF crew, and maybe Cougar, you can answer this. Because in most of these cases with implementation, when we're talking about health and resilience, for me, I'm also looking at sustainability of these health systems. And in a way, sometimes of these projects of health systems, at some time you have to wrap up things and go. So what is the exit strategy of these health systems that have been in place? Because we don't want to risk in a fault of creating dependency. And I know for some case studies, whether it's in Somalia or maybe in Uganda, or where it has created gender power dynamics of where there's, they say like, oh, now UNICEF is my husband and take care of my kids. So what is the exit strategy like in your systems or your modeling or your implementation plan? And how is that really aiming at creating sustainable, resilient health systems? Thanks.
Thank you. Excellent question that I think also speaks to the themes addressed by some of our colleagues around not creating parallel systems, supporting country ownership and leadership, and context-appropriate sustainable solutions. UNICEF colleagues, Oscar, and Ralph, would you like to take that one? Thank you. And then we'll go to Cougar.
So I don't know if you can hear me. Please, Oscar, you could go ahead. Otherwise, I could give it a try. Okay. For everyone in the room, my name is Ralph Moreno. I'm part of the UNICEF team too. And I have two answers to that. The first one is that we work on localization, training of communities, ministries of health, and local organizations to be better prepared for managing data, not only data, but also running programs and so forth, right? So the whole approach of what we want to do is not only quote unquote putting up on fires when there is a humanitarian situation, but to create a capacity in the long run and foster the humanitarian development nexus so that when we or other organizations need to leave, there is capacity created in the community where we have worked. Having said that, your question, it's a broader one that doesn't only apply to health, but to all other programs and across the development arena, right? And sometimes it's not an easy one to actually respond or deal with, since we are aware that sometimes there are issues regarding funding, commitments, and how the international arena works. So to summarize, localization is important, but still there are some gaps that need to be covered not only by us, but for the overall international community on how we can better deal with this issue when funding is over, for example. Over to Oscar and other colleagues who may have additional insights.
Yes, this is Oscar here. I'd just like to add and my answer to focus on admin data systems. One approach that we are taking and stressing in almost all the country context we work in humanitarian setting is to work with existing data systems and to discourage as much as possible establishing parallel data systems. And looking at system strengthening, focusing specifically on capacity development, targeted capacity development of staff within the line ministries, the data owners, basically. Another way we're doing that is you find in some context partners still go ahead and form parallel systems. That's because admin systems in those contexts either completely collapsed or they're collecting data that is not relevant to the emergency. In that case, what we do is then in the recovery phase, work with partners through clusters, sectoral clusters and information management clusters to integrate the systems that they established, as long as they are relevant and the data is reliable, to responsibly integrate it back into the government mainstream system. Of course, there are some cases in countries where there's not much we can do. We're actually doing the opposite. A good case in point here is Afghanistan. We know that the authority there is Taliban, and there is very, very, very minimal capacity there within the Taliban government to maintain, for example, HIS. And so what we've done in that country is completely taken over that role. The HIS in Afghanistan is run by UNICEF. And in the event that the authority changes, then we'll look at ways of responsibly handing that the system back, of course, with a focus on building and restoring capacity to where it was before the crisis, before the Taliban took over.
Thank you so much, Oscar. I'd like to leave a little bit of time for the MIHR RMS team to also respond. And I thought it was really provocative that you also addressed your question to that team, because one might say, oh, but this is a very small scale, costly, special study. You know, how does this respond to, considerations around sustainability? So if I might actually put the chief of party for MIHR in the DRC, Dr. Eta, on the spot. He wasn't able to join us today, unfortunately, or this week, but he should be online. Dr. Eta, if you are online, might we ask you to offer a reaction? It seems we might have lost him on the connection. So I'm looking suggestively at any of the RMS team who might like to respond.
Well, I think it's the best question that you could ask right now. And it's an ongoing challenge for sure. I can give you the same buzz terms as, we're capacity strengthening and localization. I can say, well, if it's really going to be transformative resilience, then there's going to be governance. And all that's true, but we have a history in public health and development of packing up our bags when the funding runs out. So I'll just be honest, I don't disagree with everything you said and with your concern. I do think from an evaluation standpoint, and this goes back to your question on climate as well. I forget your name, the student from Cape Town. we're really talking about shaping hearts and minds when it comes to your question. And I think in addressing how do we engage and enable governance to fill in the gap once aid leaves, I think both of those are addressed with really quality data. And so it feels like a cop-out to me a little bit, but I also really believe that. I think it doesn't just take one good study, one good RMS, one amazing peer-reviewed paper. It's an accumulation, and you have to have so much patience in this line of work. It's so frustrating, but we accumulate data that shapes the hearts and minds of everyday citizens and of policymakers and government leaders who will ultimately make the really challenging decisions to use limited resources in areas like climate and in areas like, sustaining health systems. So I so wish Dr. Ada could answer. Maybe, Isabel, do you want to take a turn at that? Because you're clearly more on the programmatic side and can answer that much better than mine. I was probably too honest.
I wanted also to mention that beside the RMS, as we mentioned, was more focused on household level and people, individuals. We're also looking in other, not in DRC, but in other places as you mentioned at the beginning, in South Sudan or Niger. We also kind of piloting another tool that's looking at system level. So the resilience for system that we've already applied several times in market systems. We're now trying to apply it to health system as well. And for example, I have an old map of that, the health system, for example, in South Sudan. And we can discuss it later. Some of you would like to understand. And looking at the health system, how it functions, for example, right now. And we see that, for example, more than 56% of the population, for example, right now has been providing health services through unregulated providers. Only 44% are within the regulated health service sectors. And of all of those, everything's coming here. You can see in big red, it's coming from external donors. That's for South Sudan. And that's the current map. And for example, the health pool, that's from the Health Pool Fund, and we know that the Health Pool Fund in a few years will disappear. So this one will disappear in a few years, and the whole system is collapsing because it's only 44% under-regulated and provider, and we know that will disappear, so all the rest here will disappear. And that's not even considering external shocks. So what we do with that, after that, we'll try to map how the system works. Now we also try to model it through different shocks. And we look at the determinant factors of resilience, as we know, connectivity, diversity, redundancy. We look at participation, governance, learning. So we try to map those things. And then we try to look at what could be the ideal system. And so we map changes on how we can make a system more performant, more inclusive, and more sustainable, and then more resilient as well. So that's also something we're testing in Niger and South Sudan. That's another level.
Nefra, may I throw in a last comment on this issue, because I think it's like something we haven't talked about. One of the issues with sustainability is really the higher education sector in many countries has been ignored. And some of our best cases of sustainability have been building these schools of public health that become leadership machines in country and are able to ensure that type of sustainability.
Thank you, Nancy, and thank you, Isabel. I'm not sure, Isabel, if you would be amenable to sharing that beautiful mapping, systems mapping. Yeah, afterwards, we'll compile it along with the slide decks and a summary report of this session to share with those afterwards. We have one colleague who has been very patiently waiting in the room, so I will give the mic to her now for just the couple of minutes that we have remaining.
Thank you, Nefra. I'm Dorothy Moroki with APT Associates. I'm Chief of Party for USAID Uganda's Resilience Flagship Programming it's a mouthful, integrated community agriculture and nutrition programming. So yes, to the question around, are any of you working through the health sector to improve nutrition resilience? And just very quickly, our work has entailed, and thanks to Tango, I think there's someone from Tango in the room, but we've been able to adopt the Tango tool to use it as for a participant survey 3 times over a 5-year award from 2018 through 2023 now. And we went further into the data that we collected with about over 3,700 program participants. And there were some interesting findings that we have found in as far as nutrition is concerned, because nutrition is one of the elements in our integrated and multi-sector program. So we're working on livelihoods, nutrition, with a focus on malnutrition, pregnant women and lactating women, and children under 5, and then community governance, just to show you that it's integrated and multi-sectoral. So in as far as nutrition is concerned, we found that there was our findings showed that as far as the minimal acceptable diet is concerned, households where women empowerment was that women could make decisions around, they can have a kitchen garden, they know they have some authority decision making in what they can use their property for. These are 3 regions in Uganda, 8 districts. And so ordinarily, women would be told what to do with the garden. But now, where women had the capacity to make those decisions and therefore have a kitchen garden or a perma garden, that there was an upward movement of that. And then their wealth status, the household, what was going on in the wealth in the household, and that largely is around savings. They were part of a savings group, a VSLA. And then they also had a productive asset. I'm just giving some example. And then they had some media exposure. Our work has entailed a lot of effort with a robust SBCC programming, where nutrition was identified as one of the core behaviors that the communities wanted to adopt and as part of their resilience journeys. So all that just shows that, yes, it is important. This is what we talk about, that integration, because think about it from a resilience and a household perspective. It's the same woman or the same household, it's the same community. So if not integrated, then you have somebody, a VHT coming in to talk about health, to do the to do the malnutrition measurements and so on. Then you have in our work, we've called them business service providers, the people who are supporting the livelihood journeys of the communities. Then you have somebody else coming in to talk about, come and participate in the community. But the integration, what we found is that when the village health team, the VHT, I'm sure that's nomenclature that we are familiar with. When the VHT, the capacities were built around, yes, they are working nutrition, but also they knew something about agriculture and they could support the household, so that even in the MICAN groups, the MICAN is an acronym, but as they gather to talk about nutrition, and this is the mother, infant, young child, these are groups that we formed. But in there, they're talking about savings, they're talking about nutrition, they're talking about all these things, and the VHT has the capacity to lead those conversations. Then this kind of trend, because we saw that in between 2020 and 2021, the MAD was moved from 5.1% to 9.6%. And we were like, wow. So I think the important thing is that this is important, and so it's good we're having this conversation. But the one question that begs for us to think about is the utilization of this data and the feedback loop. So utilization at every level. At the local level, the health facility, what's the health facility going to do with this data? They should do something with it, but do they have the capacity to? They are busy doing many other things. How about the district? How about the line ministry? And that, I think, is an opportunity for us to think about that and enhance those capacities, so that as we think about measurement, yes, we are collecting data, and but who else? Is it is the other sector being able to use that data? I think that's a very important thing, and it would be great if we had time to hear people's perspective about that, but that's a challenge. Thank you so much.
Thank you so much. What a rich sharing of experiences that we also hope will be documented as the Uganda activity comes to a close, so that it can be shared. What an important reminder about not only the generation of timely quality data for use, but also how is the data going to be used, by whom, and how is it going to be owned? We are going to unfortunately have to leave it there. Please do come find Dorothy throughout the rest of the week. If you'd like to leave your contact information with me and with my colleague Nate, for those in the room, please feel free to do so before you leave. We would love to keep in touch. Again, among the proceedings for this week's forum is going to be a summary report for this session in particular, the slide decks with all the questions and the rich data analysis that you've seen and heard about today, and that beautiful health systems mapping that Isabel shared that looks like a beautiful work of art. So with that, I'm going to thank all of our presenters and panelists, all of you in the room, and all of those who joined us online for a very engaging discussion. We hope you enjoy the rest of your day and the rest of the forum. Thank you so much again.